Welcome to this explainer. Okay, today we are getting into something really fascinating. We're looking at the transition in homeopathic medicine from pure theory, the materia medica, straight into the high-stakes, real-world reality of safe clinical practice. Specifically, we're diving into Samuel Hahnemann's aphorisms 146 through 153. If you've ever wondered how on earth practitioners take hundreds of remedy profiles and safely apply them to a living, breathing person sitting right in front of them while prioritizing safety above all else, well, you're in exactly the right place. Let's get into it.
So here's our roadmap for today. We'll be going through 1. Matching the two pictures. 2. Clinical triage and red flags. 3. Removing obstacles to cure. 4. The tripartite symptom valuation model. And finally, 5. Prognosis and safety netting. I want you to literally put yourself in the shoes of a responsible practitioner today. Think of this as your step-by-step clinical guide.
Section 1. Matching the two pictures. Connecting patient and medicine.
All right, so this brings us right to Hahnemann's aphorism 146. Think of this as the ultimate matching game, but with real health outcomes on the line. The core challenge is comparing two totally distinct sets of data without ever mixing them up. On one hand, you've got the patient picture. That's their symptoms, their clinical diagnosis, pathology risks, and their whole personal context. On the flip side, you have the medicine picture, which is the healing power drawn from proving observations, toxicology data, and verified clinical confirmations. The principle of similarity? It's basically a highly rigorous, hypothesis-driven matching process between these two pictures. It's absolutely not magic, it is systematic data matching.
Section 2. Clinical triage and red flags. Safety comes first.
Because before any remedy is even considered in that matching process, you, as a responsible practitioner, have to evaluate clinical boundaries. Imagine you're in the clinic. A patient walks in complaining of severe head pain. You have to ask yourself right then and there, wait, is this just a minor headache, or are we looking at a medical emergency? It's a high-stakes scenario, and how you answer dictates literally everything else that follows. Look at the stark contrast here. Let's say it's a dehydration headache. It's mild, it passes, and there's an obvious benign trigger, like, hey, maybe they didn't sleep well, or they just need a glass of water. That's a minor indisposition. But what if it's a thunderclap headache? You know, that sudden, worst ever pain, complete with neck stiffness and photophobia. Boom. That requires an immediate emergency room referral. You have to rule out something life-threatening, like a subarachnoid hemorrhage. The absolutely crucial takeaway here is that you must know the life-or-death difference between a minor issue and a neurological red flag. Patient safety always takes absolute priority over homeopathic differentiation.
Section 3. Removing obstacles to cure. Clearing the path.
So that transitions us perfectly into aphorism 150, and this highlights a really profound clinical truth. Sometimes the best medicine is actually no medicine at all. Enter a concept called causa occasionalis. Basically, this is a maintaining cause. It's a continuing external, physical, or environmental factor that is physically keeping the disease active. Hahnemann was super clear about this. As long as a maintaining obstacle is in the way, even the absolute most perfect homeopathic remedy is not going to cure the patient permanently. You simply can't hand over a remedy and completely ignore the environment that's causing the illness in the first place, right? And these obstacles pop up everywhere. On an individual level, we're talking about chronic sleep deprivation, not taking medications as prescribed, or, trying to survive exclusively on 5 cups of espresso a day. But they can also be systemic. Things like workplace chemical hazards, living in a mold-infested house, or even severe financial stress. As a clinician, you really have to play health detective. If your patient is working in a toxic environment and keeps getting recurrent dermatitis, you have to identify that and remove those daily physical blocks, whether that's through lifestyle counseling or a referral, way before you can expect a dynamic remedy to act effectively.
Section 4. The tri-partite symptom valuation model. Ranking the clues.
Now, what's really interesting about this model is that when you're filtering all this case data, you very quickly realize that not all symptoms carry equal weight. This valuation model beautifully shatters the myth that homeopaths just ignore modern medicine. We actually rigorously rank data across 3 different axes. Axis 1 is clinical urgency. This is where we identify those red flags that scream immediate emergency management. Axis 2 is diagnostic pathology. These are the common symptoms that tell us the disease etiology and stage. And Axis 3 is homeopathic differentiation. These are the peculiar, unique symptoms that actually guide the remedy selection. So it always goes safety first, diagnosis second, and individualization third.
Once we've got safety and diagnosis locked down in those first 2 axes, we turn to aphorism 153.
Samuel Hahnemann famously wrote, and I quote, "Give primary and almost exclusive attention to the striking, singular, uncommon, and peculiar signs and symptoms." Basically, this means you, the clinician, are on a hunt. You're looking for the absolute most unique clues, the individual characteristics, to find that perfect remedy match.
Let's break that down a bit more to really get the distinction. Common disease symptoms are super useful for your diagnosis. A cough in a patient with pneumonia, totally expected, right? High diagnostic value. But it gives you zero help when you're trying to differentiate and choose a specific remedy. On the flip side, you have characteristic symptoms. These are the really peculiar ones. Imagine a patient with severe burning facial pain, but paradoxically, they feel so much better when they hold warm water in their mouth. Now that is a characteristic clue. That's what you use for remedy selection. Just remember, common symptoms tell you what the disease is, but those highly peculiar, characteristic symptoms tell you who the patient is.
Finally, Section 5, Prognosis and Safety Netting, the monitored hypothesis.
All right, this brings us to the final stage of our clinical journey today, prognosis. It must always be framed as a monitored hypothesis. It is never, ever a guaranteed certainty. Ethical communication means you never overpromise a cure. What you do instead is track real, actual clinical change over time. You look at objective, multidimensional outcomes. How is their vitality? How's their sleep quality? What do the clinical biomarkers say? And to do this safely, we lean heavily on the 4 pillars of effective clinical safety netting. Step 1, give explicit warning symptoms. You need to tell the patient exactly what signs mean they are clinically deteriorating. Step 2, define precise timeframes. Let them know exactly when they should expect to see an initial response. Step 3, provide clear action steps. Give them crystal clear instructions on what to do if those red flags pop up, like going straight to the emergency department. And Step 4, write down confirmation in records. Document every single bit of this advice clearly. That is exactly how you properly protect a patient if an unexpected medical event happens to occur.
As we wrap up this explainer, I want to leave you with something to really chew on. Since the most distinctive symptom never, ever outranks a red flag, how will this rigorous safety framework change the way you view holistic clinical practice? It really highlights the incredibly deep, responsible clinical reasoning that goes into homeopathic medicine, doesn't it? It's all about balancing the art of individualized healing with the uncompromising science of patient safety and interprofessional care. Thanks so much for joining me to explore this truly fascinating clinical transition. Keep questioning and keep learning.